Good afternoon, everyone. Thank you for joining me. Today, I am joined by the Secretary of Health, Kim Malsom-Risden, and then also Dr. Allison Settle, the Chief Medical Officer at Sanford Health. I know there's a lot of information out there, but there is also a lot of misinformation, and I wanted to give an opportunity for all of your questions to be answered about the hydroxychloroquine trial that is ongoing in the state of South Dakota that Sanford, Avera, and Monument Health are all participating in. So I've invited Dr. Settle to come here today and provide an update on how the trial is going and answer any questions that you might have. And with that, I'm going to turn it over to Dr. Settle. Go ahead, Dr. Settle.
Thank you, Governor. Thanks so much for having me today. Sorry for a little bit of my technical difficulties at the start there.
Well, that's all right.
I am pleased to announce that the hydroxychloroquine clinical trial that we've undergone is called PEPCOH, P-E-P-C-O-H. It did open on Thursday, May 14, and we have enrolled a few patients into the clinical trial already. There's been a lot of press around hydroxychloroquine and a lot of altering information, different information about hydroxychloroquine, and it makes it very concerning for a lot of Americans. I think it's received more press than just about any other medication I know of today, and for good reason. Everyone's looking for solutions. Everyone wants something that's going to help with COVID. The clinical trial that we're undergoing is a clinical trial around prophylaxis, which means preventing the illness, which is quite different from what you're seeing in a lot of the literature. The concerns about hydroxychloroquine is much more around the end stages of the disease, significant infection, and individuals that are in the hospital. So what we're trying to do is a double-blinded, randomized, controlled trial, which is really the gold standard for testing and for experimentation and for clinical trials, to see if indeed hydroxychloroquine can prevent this illness. So it's for individuals who have not tested positive but have been exposed. We're looking at individuals in nursing homes that might have been exposed by an employee or another nursing home resident. So there's been an exposure. And I would say it's similar to, if you think about Tamiflu. Oftentimes we give Tamiflu very early in the disease to try to prevent that individual from getting very sick from influenza. We're trying to see, based on what we know around the mechanism of action of hydroxychloroquine, if that's truly something that would happen. So we don't know the answer. By doing a randomized placebo-controlled trial, we'll give some people placebo, some people hydroxychloroquine, and we'll measure outcomes, and we'll be able to say yes or no. I'm not invested in if it works or if it doesn't work. What I want to know is an answer so that we can move forward. And that's really what we're trying to do at all stages of the disease, is look at different things that might help in terms of preventing the disease or in terms of helping those that are very sick to recover from the disease.
So Dr. Settle, we had a few technical difficulties there and lost audio for a little while. So I'm going to ask you a few questions, and I'm wondering if you would answer them. We may cover some of the information you've already shared, but I still think it would be good, and for the benefit of the audience, that when we lost that audio, they just may not have gotten the information. But how does the WHO decision to pause the use of this drug in its clinical trial impact the South Dakota study?
So I think the WHO is using it in a very different situation, and they're much more using it on the inpatient setting and those individuals that are critically ill. What we're doing in our study is looking at a very small dose of hydroxychloroquine in healthy individuals that have been exposed, and try to see if, similar to Tamiflu, it doesn't prevent you from getting the illness or prevent you from getting very sick from the illness. So we're giving a dose that's similar to what hydroxychloroquine is used for, preventing malaria. So if anyone has traveled to an area where there's malaria, they've likely taken hydroxychloroquine a couple doses before they leave, doses when they get back, to prevent malaria. So we're using that kind of a safe dose in those individuals that have been exposed to COVID.
So, Dr. Settle, why is it important to continue the study that you're conducting when other studies have been reported to show no help and even harm, according to some reports that we've heard?
Yeah, and it's a good reason to always keep up with the literature and make sure that the question you're trying to answer is a good one. The reason why we need to continue this trial, and while this trial is so important, it's because it's at a very different stage of the illness. Much of the data that we've seen where it's shown hydroxychloroquine is proven to be harmful or not have any benefit has been on those individuals that are very sick with the disease and are in the hospital. The mechanism of action of hydroxychloroquine really doesn't make sense in those individuals. So I think we've learned something. We've learned that in the hospital might not be the right setting for this medication. There are several studies out there looking at prophylaxis or prevention with hydroxychloroquine, and this study is one of those.
So, Dr. Settle, a lot of people have talked about the New York study, that it didn't impact mortality rates and that it wasn't effective. Can you reference specifically how your study is different than that study specifically? Because that's the one that's been covered so much.
Exactly. You know, that study was really kind of a registry. So it wasn't a randomized placebo-controlled trial, but rather it was looking at a bunch of cases of COVID in New York City with a lot of different things happening. And they were able to, what they're trying to do is pull out signals from a lot of data. And one of the signals they pulled out was patients in the hospital that were given hydroxychloroquine didn't do any better. The outcomes weren't any better. So registries, while they do help provide some of those signals, don't tell us a definitive yes, no. A randomized placebo-controlled trial is a definitive yes, no. We'll give 1,000 people a placebo. We'll give 1,000 people the hydroxychloroquine. At the end of the time period, we'll be able to tell, did the ones that got hydroxychloroquine not get COVID, even though they were exposed just like the others? Or did they get COVID anyway, so then hydroxychloroquine didn't work? Or if they did get it, were their symptoms significantly less severe than those who got the placebo? So it's a true head-to-head yes-no answer. The New York one is a registry looking at a lot of noise, a lot of data on a lot of things that happened in New York City. And what they were saying is, you know, with everything going on, these patients were getting a lot of different treatments. Those in the hospital getting hydroxychloroquine didn't do any better in terms of fatality rate. So it's good information. And that's why probably we're not looking to use it in the hospital setting so much anymore, and why the WHO had the reaction they did. That's not even a apples to apples comparison. We're doing something completely different. And I'm so pleased that we're collaborating to do this work. I think it's so important to be able to bring answers to the table and be a part of that here in the Midwest. So I'm grateful for the other two health systems to be a part of this work. And we've been meeting frequently, weekly, with their physicians and our physicians to kind of craft the right trial that still makes sense while looking at all the evidence as it continues to come out.
I think folks have also asked us quite a few questions about the study that often gets reported as a VA study. I don't know if that's the accurate way to report that study, because I don't believe the VA even conducted it. But that's the way it's been reported many times in the press. But that study, they talked about it actually doing more harm and causing death. Could you reference that study and then inaccuracies of how it lines up with what we're doing here in our state?
I think pretty similarly to the New York study, in terms of the VA study was really looking at inpatients, large numbers, not as well controlled, kind of a lot of different scenarios. So it'd be like trying to pick out if, 5 different makes of a car had the same safety record versus looking at only one make of an automobile. I don't know. That's kind of a an odd scenario, but it's looking at, you're not comparing apples to apples, but you're drawing kind of inferences. And that's unfortunately a part of what we have to do early on in the stage of a brand new disease, is we're looking for any red flags or any signals, which is good. But there's never been any documentation or information from the CDC or the WHO that using this in a prophylactic randomized trial is putting patients at risk and is a concern. We're being very selective in the patients. We're making sure that they don't have any potential harmful heart conditions or anything that would put them at risk. We're carefully examining their medication list so that we know that there's no interactions with medications. So we feel very confident that this is a safe trial, that hydroxychloroquine is a medication, that the doses that we're using have been around for decades, and physicians have been prescribing it for decades in a very similar fashion. And we're being very careful, just trying to be part of the science to potentially provide a solution.
We still get some questions of people wondering if this is taking medication away from patients who need it for the treatment of other diseases. Could you speak to that?
Yeah, and it is a concern. And I think very early on, when there was a lot of hype about hydroxychloroquine, there was concerns that there were physicians that were just prescribing it, thinking it might work. We early on as a health system talked to our physicians and said, don't know yet, we need to do this in a clinical trial. So let us put a trial together rather than just prescribing it to your patients. Please, we have patients that do need this medication, and we need to use this in a clinical trial. In addition, by doing it in a clinical trial, what the pharmacies have on hand is for prescriptions from physicians to those patients with medical indications like rheumatoid arthritis and the like. So as far as we know, we are not taking those supplies. And it was really your ability to go into that federal cache to bring that medication that we could do it in a clinical trial. So where this is a completely separate cache of medication that does not get into the pharmacy supply of medication, that still that chain of physicians prescribing for patients continues on. What we're doing here in the state of South Dakota is using that cache that from the federal government, that the study will then supply that medication. So two very separate routes to get the medication.
Has the study in South Dakota been impacted at all by President Trump talking about this medication?
You know, I don't think so. I think what it does is it just raises awareness, and it's an opportunity to communicate even more. Certainly an understanding of what we're doing and how we're doing it. It's complicated, right? All of these, I think clinical trials in general are. Understanding what's going on is complicated. So it just is a reminder to us to continue to communicate what we're doing. Which is why I appreciate this opportunity. The more we can get the message out there of what we're doing and why, and how we're doing it in a safe way, I think is important. And then it's always at the end of the day, the individual patient's opportunity and decision. Do they want to be a part of the clinical trial? You can choose. And we are finding patients and individuals that are wanting to sign up for the clinical trial. So we will keep offering it as an option, and individuals can make that their choice and have a good conversation with a physician about what are the risks and the benefits, why we should try this clinical trial. They might not get the med, they might get the placebo. So, being a part of science is a wonderful thing.
Well, thank you for being here and answering questions. These are questions that our office and our Department of Health have gotten quite a bit, so we wanted to see if you would be available to address some of them, and it's been very helpful. Is there anything that you talked about in your opening statement that may have gotten cut out during the audio glitch that you want to just cover one more time to make sure that the folks at home have the information that they need?
I think your questions were spot on and really addressed all of those concerns. So I don't think that there's anything that I have to add. I would say if there's any questions and if they need information about enrolling in the study, I do have a phone number, and that is 605-312-6023. I'll say it one more time, 605-312-6023.
Wonderful. Well, thank you so much, Dr. Suttle, and to Sanford Research for your continued commitment to helping people that are affected by this virus. Having a therapeutic and a medicine that could help them gets us a long ways towards feeling better prepared for what's ahead of us and also getting towards finding a cure. So Once again, thank you so much for all that you've done throughout this pandemic, and will continue to do, I'm sure. Get some rest. Thank you. Well, if you'll stay online, if you don't mind, just in case there is a follow-up question, that would be great. With that, let's open it up to any questions that anyone may have here in the room or on the phone as well.
Yes, JP at KOR News Radio.
Yes, go ahead, JP.
Thank you. Good afternoon. Dr. Settle, could you once again differentiate between the differences between the World Health Organization doses and the doses that your study is using?
I would have to look up the doses for the World Health Organization. Our doses are similar to a Z-Pack, if you will. There's a loading dose that you would take, and then you take pills for the next 4 days. The way the medication works is that it stays in your system for an extended period of time, similar to azithromycin. As in a Z-Pack, you get a loading dose and you take a dose for several more days, and then it stays in your system for up to a month. And that's how it tends to work in terms of preventing malaria, and then also potentially preventing COVID-19.
Thank you.
This is Morgan at Rapid City Journal.
Sure, go ahead, Morgan.
I don't know if I missed this when the audio cut out or something, but did you say how many participants are a part of the trial and how many have recovered, how they're doing, and where the bulk of them are from?
So the trial got started on May 14th, and we're just enrolling individuals. What we do after enrollment is we randomize to either get the placebo or to get the medication, and then we don't know which they get, and then we monitor and we kind of track for symptoms and the development of COVID. If they develop symptoms, then obviously they would get the COVID test. If they did not, they would not get the COVID test. But we follow those individuals for approximately 45 days from enrollment in the trial. So we're collecting data, and we really cannot provide data until we get everything back. That's kind of the nature of a clinical trial. We don't know who's getting which, and we're just going to collect the data and then report out once we have the 2,000 participants.
Have you met the 2,000 participants yet, or do you have a preliminary number of how many are on it today?
It's only a handful today, and but that will increase over time. There's been a lot of logistics to get it up and running, so having it just started on May 14th, it will increase. People need to kind of develop it into their workflows as they identify individuals who have been exposed. Thankfully, with a lot of the wearing of masks and a lot of the social distancing, individuals are not having a lot of exposure. So there is still some community spread, but the steps that we've taken and the steps that we are taking to really just be careful and take care of each other really does prevent a lot of those exposures.
Did you have a concrete number on how many participants there are yet, or not?
I don't. I can see if I can get that for you, though.
Sure, thank you.
This is Stephen Groves from the AP.
Sure, go ahead, Stephen.
Dr. Settle, so just so I understand, the people that are enrolling in this is it people who have tested positive for COVID-19 or who have been exposed, in their family, in their home, or at their workplace? And how do they find out about the trial? Is it through their healthcare provider?
Yeah, so good clarifying question. These are people that do not have COVID, so they have not tested positive for COVID. And they will find out about it through their healthcare provider. So it's oftentimes going to be an employee. So many of the health systems across the state we have our own employee health, and if we have an employee that's been exposed, we have to notify them of their exposure, and then we can offer them, if they're interested in the clinical trial, we can offer them the clinical trial at the time that we notify them of the exposure. We're giving them information as to how to keep themselves safe, how to protect themselves, to stay home and quarantine, et cetera, if there has been that exposure. And to look for symptoms. What are the symptoms? when they need to contact their healthcare provider, et cetera.
Further questions? Okay.
I have another question, if that's okay.
Sure, go ahead.
I might be wrong here, but I remember there was a few different components to the study that was introduced at first. So there was, I think, a hospital registry, correct me if I'm wrong, and then at one point there was 2 different components to this study. Can you tell me, first of all, if that hospital registry is continuing, and then if one of the components was changed, or where we stand out with those components?
Yeah, excellent question. So the hospital registry is continuing on. That is just like New York, where it's a registry of all COVID positive patients that have been in our hospitals. All different things happen to those patients. And there were some cases where we were treating patients with hydroxychloroquine in the hospital setting. But those physicians, those critical care docs that meet regularly and discuss the literature, are now saying that hydroxychloroquine is not useful in those scenarios. So we are not using it in those inpatients, and that is a pivot, and that's because we've learned more about the use of hydroxychloroquine, again, as a registry. In a clinical placebo-controlled trial, there is still a potential to use hydroxychloroquine, but we are not a part of any of those clinical trials. So that's very observant. Early on, when we talked about the clinical trial, there was the registry component and then this placebo-controlled trial. The registry component, that's really just monitoring patients that are in our hospitals with COVID. All different things are happening there: convalescent plasma, remdesivir, proning patients, using ventilators. It's data collection, data gathering. The physicians on the front lines are making decisions based on the science, what they should be using and should not. And we are seeing a pivot of our physicians to not using hydroxychloroquine in that inpatient setting. So we'll continue with that registry, but we won't see further patients getting treated with hydroxychloroquine, if that makes sense. The placebo-controlled trial, we've been modifying over the month of April and really working with the physicians at the different health systems to come up with what makes the most sense. Looking at other clinical trials that are happening, looking at the new data coming out about hydroxychloroquine, and settling on the current trial as it is today, which is really looking at exposure, healthcare providers, individuals in long-term care facilities, where we can very closely monitor those individuals, knowing what their medications are, what their medical history is, and then it's a 5-day course of a medication of hydroxychloroquine or placebo. Does that answer your question?
Yes, thank you.
Any further questions? Okay. Again, Dr. Settle, thank you so much for your time today and your insight, and I appreciate it. Thank you, everybody. Have a wonderful day.